Hi there, I'm Steve Duvall, West Coast Therapy Specialist. Today's training is on falls. When we talk about falls, we're talking about, yes, falls when a resident is walking and falls, but also falls due to transfers, going from their bed to a wheelchair, or from a wheelchair to another chair, or even back to the bed. So what we want to talk about first are what are the warning signs for someone who is at risk for falls. We know that people who are confused are at higher risk for falls because they might forget to use their assistive device, or they might forget to use their walk or their wheelchair or what have you. But also people who have instability, or either they've come back from a hospital or rehab, they're weaker, they're unstable on their feet. Some of them might even be unstable sitting unsupported, sitting on the side of the bed or sitting in a chair or a bench. These people are definitely at risk for falls. People who have weight-bearing issues, let's say that they have a wound on their foot, let's say they have swelling in their feet, let's say that they have diabetes and they're insensitive in their feet, they can't feel things on their feet. They are going to be at higher risk for falls. Let's say that somebody has a sprained ankle or had a fracture hip or something of that nature, and so weight bearing is an issue for them. Them being able to put the proper amount of weight comfortably on their foot. Others are people with different illnesses. Some of the illnesses that we see that are common in people who also have falls are people who are dehydrated, which we've done trainings on dehydration. People with UTIs, we've done training with people with UTIs. People who have low blood pressure, okay, which is hypotension. People who have diabetes that we talked about. The feet are insensitive. It's called an insensate foot. And people who have had a history of falls are more likely to fall again. So those are your folks that you should be looking at. These are your folks who have higher risk of fall, and those are the warning signs that you know of someone who might have a fall. The results of falls, we all know them. One of the biggest ones is somebody goes out to the hospital. And why they go to the hospital is anything from having a shoulder fracture, hip fracture, a femur fracture. They can fracture their ankles whenever they fall. One of the important things is someone that with osteoporosis, they can go to stand up or go to turn, and their bones are so fragile that they can twist, the bone can break, and then they fall. So in that case, the fall didn't cause the fracture caused the fall. Some of the other results, some of the more grim results from having a fall are head injuries. You can have skull fractures. You can have things such as brain bleeds whenever someone has a fall, hits their head, and it's called subdural hematoma, and that's where the brain is shaken when someone falls. There's an injury to the brain, and the brain starts filling up with blood. If that happens, they have to have relief of their skull or they will die. So that is one of the things that can happen. Ultimately, falls can cause death in an elderly person if it's traumatic enough. So you see the importance of making sure we see the warning signs, that we heed the warning signs, that we make sure that we go to this next part, which is the prevention of falls, okay? And this is something that we all have to watch as caregivers in a facility where we're taking care of the elderly. Biggest thing that we can do to prevent falls is planning. We've got to plan to make sure that we are checking on the resident very frequently, hourly, and someone who is at higher risk maybe more frequently, especially if we put them in a position where they're not lying in bed, they're sitting somewhere, or they're waiting on something. We got to go back and check on them, because if they're confused, they're going to forget why they're there. They're going to get up, and if they're at risk, they're going to fall. And we know the detriment of that. So having a plan, making sure that we plan for particular residents, and that's a customized situation. We have to make sure that if Miss Smith is at risk for falls, we put a plan in place to make sure that that fall doesn't happen, especially on our watch. So the frequent checks, definitely part of that plan. Having the right assistive device is very important. in preventing falls. If there's something wrong with a walker, bad wheels, bad brakes, unevenness, the wrong setting, the wrong size, making sure that the assistive device, whether it's a walker or a wheelchair, is in good working order. Another thing we can do too is when we put a resident back in their bed and we know we need to keep them there, get that assistive device out of sight. If they have had problems using that assistive device, if they're impulsive and are going to grab that assistive device, if it's out of sight, then they're less likely to get out of bed and use that device to go somewhere if they are dependent on that device. Again, that's a customized situation. We have to look at that on a case-by-case basis sometimes. One of the big things that we can do is make sure that we are transferring these patients from their bed to a wheelchair, from a wheelchair to another chair, the right way. Because if you're a 90-pound care associate and you have a 250-pound resident my size, that's going to be tough for you to transfer me or a resident like me and my size safely from the bed to a wheelchair or wherever you're going. So you have to think about the transfers. If you need help with a transfer, make sure you get the help. Or if it's not a size issue, make sure you're using the right technique. And we're going to go over that in a demonstration in this video. If there is someone at risk, we need to consult therapy. Make sure therapy checks on them. They might need to be on therapy. We might need to work with them in therapy. Occupational and speech therapy can work on those transfers, on balance, on strength, on their ability to ambulate within the facility or even just in their room in a safe manner. So one of the things we're going to do is we are going to have a demonstration on transfers and on the proper ambulation.
Hi, my name is Pepe Rossway and I'm the occupational therapist. And I wanted to talk a little bit today and do some training on transfers. First thing I want to always tell you guys is that with the use of proper body mechanics and setting up the patient, you're going to reduce the amount of work you have to do and significantly reduce your risk for injury. So I'm going to start today first with a wheelchair transfer. We'll do a stand pivot and a sit pivot, one person. So first thing you always want to do is set up the wheelchair. And we're going to transfer them towards this chair. First thing we do is set it up. So we want the wheelchair, or wherever you're going to be set up this direction. It is the smallest angle for the transfer, and it's the safest way to transfer the patient. Next thing we always do is lock the brakes. So we want to make sure, if we can, we ask the resident if they can lock the brakes. If we can, there we go. And if they can't lock the brakes, then we do it ourselves, okay? And then the next thing we want them to do is to set up for positioning. We want to ask our resident to scoot to the edge of their seat. There we go, perfect, okay? So in her case, she's probably not needing as much help. We're going to do a stand pivot transfer first, okay? So she's already set up for it with her hands in the correct position. So we want her to push up from the chair, not pull up, okay? So I know a lot of times we try to do that. Lean forward, all right? And we're going to put our hands behind and just help her stand up. There we go. And then she's going to turn around. There we go. And then reach back with your hands, bend your knees. And then she's going to have a seat. The next one we're going to do a sit pivot. So this is going to be, the difference is someone who needs a little more assistance when they go to transfer. Again, we set up the same way. We're going to have them lock the brakes if they can, okay? We're going to ask her to scoot her bottom out to the edge of her seat. There we go. If they can't scoot their bottom out to the edge of the seat, scoot back again for me. You can help them. A lot of times the way I help them do it is that if they need a lot of help, I kind of just help pull the back of the hips and pull them out to the edge of the seat until I get there, okay? So where I need them on the edge of the seat, okay? And then we lean forward. The other thing is if this person needs a lot of help, we're going to position their feet. It's not something, usually we just have them pull their feet back. You know, you can't stand with your feet way up here. So we put her feet back, but we leave the lead foot a little bit forward. So you see where it's set just a little bit out, okay? And then I'm going to put my hands in the same place. I'm always going to ask her to help me. So she's still going to push off from here. And in this case, I'm going to lean her forward, and then I'm going to pivot her over to her chair, okay? And then we just pull her feet back, okay? So those are the two, the stand pivot and the sit pivot. The other transfer I do want to work on today and do some training on is the two-person transfer. Sometimes we get a resident that for safety reasons, we do need two people to help transfer. Unfortunately, I see a lot of times when people here are doing a two-person transfer, they think that it's the grabbing here and the grabbing here. And that's not the proper position. That's where we end up with people who have a lot of shoulder problems. They start getting pain because we're pulling on them, and we don't ever want to pull on arms, anything like that. So a true two-person transfer is going to be one person in the front and one in the back. Okay, so again, we're going to have him scoot out to the edge of the seat. There we go. We're going to do a proper foot position. This foot out a little bit. There we go. Okay, you're going to lean forward. You can have them, if you need to reach their arm out to where they're going, because it helps lean them forward a little bit. Okay, we're going to come underneath again, and then we're going to lift, and we're going to put him in the seat. Okay. Some of the things I know that when we're going to the bathroom and things like that, we tend to use the grab bar. The only issue I have with that, and that's only useful when you have a grab bar in place, but when you get to the edge of the bed or you're doing other transfers out in the community, these guys don't have anything to pull on. And it is also is more of a risk of injury to do that. So we can always remember to kind of push up and also not to pull on arms or things like that. I think we would do very well with our transfers.
Okay, welcome back. So you had your demonstration for the transfers and for proper ambulation techniques. I hope you enjoyed this. We're going to have a quick 3-question test, little quiz here that we're going to hand out. And here are the questions. Question number 1, true or false? Confused and weak residents are at higher risk for falls. Question 2, a head injury and a fractured hip can result from a resident having a fall. Yes or no? And question 3, one of the best ways of preventing a fall is to monitor the resident frequently and know the proper technique for transferring your resident. Yes or no? All right, good luck on your quiz. Thanks for watching this video.